Okay, anytime you want to start.
Yes, let's go ahead. Good evening, everyone. I was asked to just talk about hyperhidrosis, and I thought I might just run through some of the key issues. Can everyone see the slides? Yeah. Does anyone see the slides even? Yeah.
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 Okay, so I guess in relation to this, for reasons in terms of the evolution of clinical practice, a lot of you are probably seeing relatively little of this. So I went to the curriculum to see what's actually required, and you can see the list here from the curriculum is around the assessment and management of patients. There's supposed to be knowledge of the anatomy, pathophysiology, and the treatment options. You're supposed to have the clinical skills to take a history and examine a patient and draw up a management strategy. And those are either that you would know about how to do them or to be able to show that you can do them at level 2 or level 3. And then you should know about the treatment, but I don't think you're expected to be able to do it, and I don't think you're likely to be asked to do any of those procedures. But I was going to cover those issues now. So that's the level that the curriculum requires in terms of somebody who's at an intermediate level, but obviously applies to someone completing the program as well. So in terms of background, it's a common condition, and focal hyperhidrosis probably affects between 1% and 5% of the population. Lots of people don't seek medical advice for this and just manage it themselves, and we probably all know people, in fact, indeed some of us have probably had this at some stage at least. But I mean, the level at which it impacts on people socially is where it becomes pathological. And there's lots of examples of this, but people who are, typically these people will wear only black or white clothes, will always wear sweatshirts or jumpers or jackets. They'll never take them off because they're conscious of these sweat marks all the time. People with primary hyperhidrosis avoid situations where they have to shake hands. They're obviously in the clover at the moment, given the COVID-19 situation. Nobody's shaking a hand for over a year. But indeed, particularly those who are still at school level, you know, find that their hands are so wet that they wet the page and have difficulty with writing, that it interferes with writing because the pages are so wet. There's a familial component to this, but it's not a single gene transmitted disease. And I mean, partly the familial thing I think relates to awareness, and particularly those who are aware of treatment. So I have families of patients who've been coming to me for 20 years for treatment. And there's undoubtedly the case where you'll get relatives of primary patients, then friends of primary patients, and then other patients of the same GP where your initial patient is have come to me at different times over the years. So I think it's as much the awareness as it is the condition that tends to create some of this familial clustering. So part of the curriculum includes the knowledge of the anatomy. The key thing here is that this is a sympathetically mediated effect on eccrine sweat glands. So eccrine sweat glands produce kind of a salty water type sweat, which is low in other components, and generally speaking, not associated with odor and those other issues that you can get with excess sweatings. So that's when you get apocrine sweating, but eccrine sweating is fairly dry, watery, salty stuff. It's driven by sympathetic innervation, and it's a cholinergic transmission, and that's important because of the modalities that are used to treat it. The other components of this are obviously the postganglionic sympathetic nerves come from the ganglion chain in the sympathetic chain of ganglia along the necks of the ribs, and the fibers from that come via the spinal cord in the mediolateral column, and the driving center for this is the hypothalamus. Equine sweat glands are concentrated in the palm, the sole, and the axilla, and to a lesser extent the scalp and the face, and lesser in other parts of the bodies, but they do exist elsewhere. And as I said, probably really important is this acetylcholine mediated. And I think it's important in terms of the diagnosis to focus on primary focal hyperhidrosis, which typically begins in childhood or adolescence. Most patients who come to us, even if they come in later life, have had this since adolescence. Its persistence throughout life affects primarily the palm, soles and axilla, and to a lesser extent the scalp and the face, and indeed other sites. Most of the secondary hyperhidrosis that you'll come across is generalized sweating and is associated with some conditions. Classically, it's part of the kind of B-style symptoms of lymphoma, but it can also occur in diabetes with many drugs. There's a list of up to 30 drugs that can cause it. It can be part of particularly latent TB. It's noted with HIV or any of those pyrexia of unknown origin type conditions like endocarditis or brucellosis. It's characteristic with certain malignancies, including lymphomas, carcinoid, pheos, and it can be a feature of hypothyroidism. And there's a big long list of those on the up-to-date site. These links are available. I'll send the PowerPoint afterwards. You can click through to the links rather than trying to catch them now. And there's been various attempts to come up with a consistent diagnosis to sort out who might be treated from those who probably don't need treatment. And these are the sorts of criteria. So it's focal visible excess sweating. There are ways to quantify it. You can quantify it using filter paper and weighing the filter paper. And you can map out where it is using a combination of starch and iodine. Typically, it's bilateral and symmetrical. It interferes with daily activities. If it's not occurring at least once per week, it's probably not significant. It occurs at a young age. There can be a family history, and it doesn't occur during sleep. It is made worse in social situations, and it's obviously worse when it's warm, but it typically affects people even if the weather's cold, perhaps reflecting the fact that we spend a lot of our time inside these days. So in terms of history and examination, the history is really to tease out is this focal hyperhidrosis rather than generalized hyperhidrosis, and do they meet the criteria for the diagnosis? I think it's worth teasing out the social impact, and if you ask leading questions, most people will have this issue with colours of t-shirts, having to wear jumpers, jackets, not taking them off, avoiding social situations where they have to shake hands, and problems with writing. It's worth finding out about previous treatments, and most people who come to our attention have already been treated at some level before this. Sometimes you can get you can get skin changes, irritation of skin from a combination of wet maceration, the agents people use to try and dry them up, and the treatments that they've had. You can quantify this, and there's two nice quality of life scores. The Dermatology Life Quality Index is a general dermatology score, and there's a hyperhidrosis specific one. There's a very good website there, My Life is a Puddle, from a lifelong sufferer of hyperhidrosis, and she has guest posters from people who've had various treatments, and includes in that recruitment into ongoing randomized control trials, of which there are relatively few. I think it's important to gather all this information to help the informed consent discussion. So any of the treatments for this are elective. You're only trying to improve quality of life. Nobody dies from hyperhidrosis. So it's really important that you tease out informed consent, particularly if you're talking about surgical treatments. And I think it's a good example of where the informed consent discussion needs to be front and centre and well documented. So the various agents work at different places along this pathway. Some work directly on the skin or directly on the sweat glands, and that would be mainly iontophoresis and aluminium salts. I'll come back to them in a few minutes. And glycopyrronium, which is an anticholinergic agent. A botulinum toxin blocks transmission between the postganglionic neuron and the sweat gland, so it blocks cholinergic transmission. Systemic anticholinergics also block that transmission, but they affect any cholinergic mediated transmission, and that causes some of the side effects I'll come back to in a minute. Endoscopic thoracic sympathectomy deals with the ganglia and obliterates the pathway from the ganglion out through the postganglionic sympathetic nerve. And then there's a new technique called mirror dry, which I'll come to later on, and subdermal curettage, which are really both about destroying the sweat glands using different surgical techniques. Most patients will have tried this before they come to us. Obviously, there's over-the-counter antiperspirants, which are all aluminium salts. And Hydrol 40 is a prescription-only aluminium salt because it's a high concentration, 20% weight by volume. People apply this overnight and wash it off. It seems to work by causing metal ions to precipitate with mucopolysaccharides and block the sweat glands. So it's probably unsurprising that skin reactions are common. And a lot of the patients who use this consistently will find that they get swollen, tender, red, inflamed skin. Some people are prepared to accept that as the price of treatment. It's particularly a problem if you're trying to use it on your hands or your feet, but it's certainly tolerable for some people in the axilla. As I said, a lot of them don't come to us. If a GP prescribes this for them, that's their problem solved. Relatively recently, in the last few years, this topical glycopyrronium treatment has become available. It's brand name Qbrexza. It's not available in Ireland. It's not licensed for use in Ireland. And what this is a cloth impregnated with 2.4% solution of glycopyrronium. There's been a couple of randomized trials showing that this is quite effective. You can get systemic cholinergic side effects, but because it's a topical agent, most people avoid those. It's expensive. It's about 20 euros a day to treat with this, and treatment lasts for a day. So it's probably never going to catch on here given the cost. We'll show you some of the comparative costs in a few minutes. But it is out there as a treatment. Iontophoresis works better for palmar and plantar hyperhidrosis. You can see the gadget down here at the bottom. You run an electric current from a machine, which is battery powered or rechargeable, through water baths. Typically you use tap water, although you can add anticholinergics like glycopyrrolate to the tap water. You treat it for 20 or 30 minutes per day, 3 times a week, and 2 or 3 times per week thereafter. Although this is widely used, it's readily available. You can buy this over from eBay for about 500 euros. And there are some reports out there with up to 80% effectiveness, but no randomized control trials that I can find. Generally speaking, I use this as first line for palmar or plantar hyperhidrosis, and the majority of patients go away with this and don't come back. Oral anticholinergics do work. Maybe 50% of people or more will get an effect from this, but up to 1/3 will get side effects, and these are anticholinergic side effects. Mainly, I use this in patients who have recurrence after other treatment, particularly surgery, or who failed all other treatments. And some people use this selectively. So if they're going to social situations where they're worried about this being a problem, they take a few of these tablets, but they don't take it regularly. There's some concern about long-term use of anticholinergics being a risk factor for Alzheimer's disease. There's no robust data to support that, but it does raise some concerns about starting younger people on these. So again, I think most people use these selectively in selected patients. This is probably the most effective treatment for axillary hyperhidrosis. So it's intradermal injection, between 10 and 20 injections of between 50 and 100 microliters into the axilla. We use Botox now, so it's 100 units divided between the 2 axillas. It's over 80% effective. It lasts 6 to 9 months, and the cost in the HSE in a study that we've done shows that it costs 389 euros per treatment based on 2017 data. It's quite painful. And Jimmy O'Riordan, when he was a registrar with us before he reached his current dizzy heights, I did a randomized trial in the clinic which showed that topical application of local anesthetic, amethicane, relieved that pain, and that's now routine for us. We get patients to apply that before they come into the clinic. Theoretically, you can get antibodies to Botox. That just stops it from working. We've had 1 or 2 patients over the years that have dropped out of our program, probably because it was ineffective and possibly for this reason, and you can measure those. And there's at least theoretically an allergic reaction phenomenon. You're injecting a protein. So I guess somebody who had a particular history of severe allergies, we might be a bit more reluctant to use it. I found it very difficult to use in palmar or plantar hyperhidrosis, and I just don't do it because of the logistics issues. But certainly the dermatology literature has lots of examples of that. And there was a very good randomized trial showing the effectiveness of this 20 years ago. Curettage is a kind of liposuction type treatment to suck out the sweat glands under tumescent anesthesia. In a randomized trial, it's less effective than Botox. You tend to get patchiness, so you get areas that it doesn't work in. No doubt it is operator dependent, but nobody's measured that. It's theoretically, though, a permanent solution, so it has that advantage over Botox that you shouldn't need to go back and have it done again. I mean, overall, there's limited data and the trials are, not ideal. So I have no experience of this. I'm not aware of anyone in Ireland doing it, at least not in the public sector. But it certainly is available and it has a role. The main reason vascular surgeons got involved in this at all was because of this operation, which was invented in the early 80s. The first report I can find is from Wheel in the British Journal of Surgery. And 2 years later, Billy Hederman published a larger series based on his experience in the matter in about 80 patients. So this is done under general anaesthesia with a dual lumen endotracheal tube. You put in two 5mm ports, one for a camera and one for a electrocoagulation device, either a grasper or a hook or a scissors. If you're dealing with palmar hyperhidrosis, you can just divide the ganglion on the second rib. To deal with the axilla, you need to deal with the second, third, and fourth ganglia. There's lots of complications to these procedures, and most of them aren't common, but they're quite serious complications. So pneumothorax that requires treatment, empyema, particularly if you get a combination of pneumothorax and bleeding. Compensatory sweating is common, and severe sweating, at least 2%, maybe higher. And Horner syndrome from conduction from the second thoracic ganglion up into the stellate ganglion is a particularly disabling complication in the sense of the cosmetic effects of it. So this is data that John Gibbons put together for a paper looking at the reported incidence of these complications in the literature. And a lot of them are reported from selected series. So even though this procedure was commonly performed, the number of cases that you can identify out in the literature are relatively small. Mirror dry is a new technique. So this uses microwaves to burn and destroy the sweat glands with a cooling system to stop a burn of the skin. So it's a complicated gadget that delivers microwave energy and cooling at the same time. It involves 2 30-minute sessions. There's one small randomized trial which showed that it was effective, at least equivalent to botulinum toxin, and in theory it is permanent. You may get altered skin sensation, which will usually recover, or a local skin reaction, which is really a thermal burn. The machine itself is quite a capital investment, so we don't have one. I'm not aware of one in the public sector, but there are a few private cosmetic clinics in Dublin who offer this treatment, and I haven't been able to get a price on the treatment, but I'm sure it's in the thousands. And I think cost is important because it's a lifelong condition, and working out what's the most cost-effective treatment is important. Probably the cheapest treatments are the aluminium salts, and even though you have to use them forever, the patients pay most of the cost of this, and it's relatively inexpensive. We've costed botulinum toxin in the HSE at €389 per treatment, and you need at least 2 treatments a year. And we've costed endoscopic thoracic sympathectomy when we were doing it at almost €9,500. In order to look at the effect of this treatment over a prolonged period, we factored in the incidence of these possible complications and the relative cost of these. And John got an insurance actuary to help him with this, and we did Monte Carlo modelling, looking at what would happen in a sequence of 10,000 patients in terms of the likely complications and what they would cost. And modelling this, what he showed was it would take over 13 years of botulinum toxin treatment to reach the same cost as endoscopic thoracic sympathectomy. So while it's a permanent solution, the side effects can be significant, and cost effectiveness wise, it's really of borderline equivalence. 13 years is a long time in terms of follow-up for most treatments. And of course, there's the small risk of catastrophic complications. So I have had a 21-year-old woman go into bradycardic bradycardia followed by a cardiac arrest during the procedure and required CPR. And there's been at least one high-profile death in Ireland because of bleeding from a vascular injury. And in Sweden, this procedure is no longer permitted for this indication because of a few adverse outcomes. So I think it probably has had its day as a treatment. And I'm not sure if there's anyone on the call who's still doing it, and that might be worth discussing at the end. The other thing we've done with botulinum toxin is there's been no long-term follow-up. The longest series is 2 or 3 years. So we followed, I've been offering treatment now for 20 years. We followed 75 patients who've had a mean of 12 treatments each, with a range of duration of therapy for up to 10 years, but looking at a median of 5. And what we showed in the study, which Alwyn Lynch published last year along with Tom, is that the treatment is effective out to at least 5 years and possibly as far as 10 years. So in terms of treatment choices for hyperhidrosis, for Palmar and plantar hyperhidrosis, you can try topical aluminium agents if they haven't been tried before patients come to see you. I think iontophoresis is first choice. Botulinum toxin is next choice. Endoscopic sympathectomy might be a choice for Palmar patients. Lumbar sympathectomy would be required for plantar hyperhidrosis, and there is a few series of this, particularly one from South America, but there is a concern about effects on particularly sexual function from a sympathectomy that make it not a terribly attractive option. And I don't know of anyone who's offering that routinely for plantar hyperhidrosis. For the axilla, topical aluminium agents are probably the best option. There is a complicated way of doing iontophoresis. I've yet to convince anyone that it's a good idea. Botulinum toxin is probably the mainstay. Curettage may have a place. Mirror dry will probably have a place, and it's really around cost effectiveness. And I think endoscopic thoracic sympathectomy, because of the extensive sympathectomy, it's particularly the axillary patients who end up with the compensatory symptoms, and for that reason I think it's probably inappropriate in the treatment of axillary hyperhidrosis really for any reason. So that's an overview of everything anyone needs to know for certainly for the FRCS level for hyperhidrosis, and I'm happy to answer any questions you might have at this stage.
Hi, Sean.
Sean?
Yes.
Sean O'Neill here. Very nice talk. I think you kind of partially hit on what I was going to say. This, essentially, in my opinion, this is not a vascular condition. And as you say, vascular surgeons got involved in it because of thoracic sympathectomy. I was foolish enough to do this for about probably 10 years, and I got sense about 4 years ago. And thankfully, my foolish colleague Prakash Madhavan has taken over it now, so I'm delighted with that. But I suppose there's a question: do you really think we should be doing this? Is this not a dermatological condition, and we really shouldn't? And you're right. I think you rightly say that sympathectomy is a dangerous procedure, and as surgeons, it's probably the only thing that we can truly offer. And should we really not be dealing with it?
Well, I definitely agree with you, Sean. The dermatologist shouldn't be doing endoscopic sympathectomy for sure. I mean, to be honest, botulinum toxin injections and managing the condition, yeah, anybody can do it. And that was my first thought when I was asked to talk about it, but it still is on the curriculum, so people are still expected to know about it. I suspect it varies from place to place. Our dermatologists don't have much interest in it, so they still come to us. But I don't disagree with you that you could move it into another environment. It's a bit like some of the other things we do, like the diabetic foot management. It's managed differently in different places. The role of vascular surgery in that too is modest. And do I think endoscopic sympathectomy should be done for this indication? I think not really, not without a lot of discussion around informed consent, and probably not without exhausting all the other possibilities first. Yeah. And to be honest, I don't offer it anymore. I haven't done one in nearly 10 years.
I was very interested to hear as well about the iontophoresis for the Palmar, and that you're going to see a lot of patients don't come back. So obviously they're either happy with it or they've gone somewhere else, but it sounds like they're happy with it.
Yeah, I think so. I mean, some of them have come back and they are happy with it and some technical issues. They have to go and buy it. And that might be a bit of a barrier for some people. I mean, I think those who are committed would be prepared to spend 500 euros on it. Those who aren't prepared to spend 500 euros might be embarrassed to come back. I'm not sure. So I couldn't swear to you what happens to them. But I mean, I think the data where you do have people who use it is that it's actually very effective.
Okay. Thanks, Sean. Nice talk.
Hi, Sean. Morgan McMonigal here.
Hey, Morgan.
Nice talk, and thanks for the overview. I do offer it. I have a few patients who come to me over the years, again, mostly younger females who have problems with the Palmer hyperhidrosis. Just with the ontophoresis, I have had a few patients who've gone off and bought it themselves, and I haven't audited it, but anyone who I've followed up with have all been very happy. But it's you have to be compliant with it, like everything else.
Yeah.
There's another thing about the axillary sweat gland resection, also called a SCOOG procedure. I used to do that when I was in the NHS. It's quite popular in certain trusts in the NHS. I haven't done it here. I almost had one patient agree to do it. And it is actually quite satisfying. Hematoma is the other side effect you can get from it. But it does actually work if it's done properly. Just with the thoracic sympathectomy, I have to agree with what Sean said. Is it a vascular procedure? Most vascular textbooks don't have anything on this subject in them, the vast majority. And I'm not aware of, certainly in North America, any vascular surgeons doing it. I might be wrong, but certainly most trusts in the NHS now won't fund endoscopic sympathectomy for that very reason. Like I said, I do offer it, and any people who've come back have been happy with the results. I did it for one chronic pain syndrome, a chronic ischemic pain, which worked at the time. I suspect it'll fall off. But if anyone on either trainees wants to look up how to do it, if you go to touchsurgery.com, we have a nice video on it, and the videos are very nice. So if they want to know about how to do it from a technical point of view, but I think it's unlikely that you'll get asked about it in the exam, but it is on the curriculum, like you said.
Sean?
Yeah, hi, Prakash.
Hi, Sean. Yeah, I mean, I think from my perspective, I think I have been doing these procedures for the last 20 years, and I still do offer it. And I suppose my cohort of patients who come to me have thankfully been through the various different treatment modalities, and I will point blank refuse to entertain them unless they have tried other modalities, okay? And I do get some people who have been referred to me from cosmetic surgeons who have tried the various other techniques. And I suppose, we are in the process of writing up the series that I've got of over 110 patients, I think, over 20 years. It's not a huge volume, but it's about as many as I suppose there are written up. And I suppose the one issue is that whether or not we should be doing it, okay? Provided the patients have gone through the various procedures, provided they've gone through a proper consenting process. And I am always very, very careful about how I consent them. Nobody gets a procedure unless they come to me at least once or twice, okay? Certainly nobody's offered it on their first sitting. I would regularly tell them, you need to go away, research it. There are various blogs about why you should have it done and why you shouldn't have it done. And I go through all the various issues, and I do refer to that one case that happened a few years ago. So, all of that is very, very clearly put. Having said that, once they come to surgery, it is not, as we all know, not a hugely difficult procedure to do, provided you set it up very carefully. I have a very regimented way of doing it. I don't know how you have done it in the past, but for the trainees, I always do it with the patient supine, with their hand on a head ring behind their head. That opens up the axilla very nicely. And I use 2 skin crease incisions along the anterior axillary fold. The highest rib interspace you can feel is usually the second. So that is my first port. And then I'd put 1 port lower down 1 space apart, and make sure that that is done in a manner that you do not end up fencing with your instruments. And yes, we use 2 5mm ports, And so far, I've had maybe one issue with a pain syndrome, and I haven't a clue how that happened. It was the most straightforward of procedures. This happened in the last year to me. I've had one patient who's had about 2 years down the road, the most horrendous compensatory hyperhidrosis. There are surgeons in Ireland who do bilateral procedures in the same sitting. I point blank refuse to do that because there is a higher risk of compensatory hyperhidrosis if you do that. And I would always space them apart 6 to 8 weeks. So, that's the way in which I would deal with these patients. And yes, I still do offer it to a very selected group of patients.
Yeah, I think they're obviously good results, and I think you'd have to be offering it at that standard for it to be appropriate to offer it at all. The challenge is that some of the complications are relatively uncommon, and in this condition, like, they're catastrophic. So I have, as I said, had a patient who got a cardiac arrest. I've seen 1 or 2 with chronic intercostal nerve pain, and I wasn't involved in that patient who died directly, but at least it can happen. So I guess if the instance that's 1 in 1,000, most people won't see it in a career, but it could still happen to any of us. So it's I think you're absolutely right. It's around informed consent, delivering the procedure as effectively and safely as possible. But there is a risk, and I don't know where the threshold should be about offering elective quality of life surgery to people where there's a small but definite risk of mortality associated with it. It's an unanswered question.
Can I just come in there again, Sean? I'd be interested in other people's opinions, and Prakash especially. Do you routinely, if you're still doing it, remove the sympathetic chain between ganglion 2 and 4? I mean, I do, and ideally you should. But some people just divide the chain below ganglion 2 and leave it at that. But then the incidence of failure is much higher because of the nerve Kuhn's. I'd just be interested in what other people's opinions are.
Yeah, Morgan, as far as the technical aspect of it is, I would use a diathermy hook. I set it on the cutting setting, and I would go onto the ribs directly and divide the nerves at 2, 3, and 4 if appropriate. The nerve of Kuhn's always is lateral to that, so I would certainly look for that. And I have probably seen a nerve of Kuhn's in maybe 3 or 4 in all the ones that I have seen. Okay, so I do look for it, but it's not very often that is seen.
I think the issue there, though, Morgan and Prakash, is what you're trying to treat. So, like, when I did this procedure for palmar hyperhidrosis, if you address the second rib and follow out along the rib to try and identify that nerve and divide it, you usually get a dry hand. If you do 2, 3, and 4, you'll get a dry arm, and you're more likely, and the data does support it, you're more likely to get compensatory hyperhidrosis.
You might be right. They say there's a 10 to 15% failure rate if you don't take 2, 3, and 4. And let's face it, this is the sort of operation you don't go back and do again. It's a one-stop shop. I'm glad Prakash is very careful with his pronunciation of nerve Kuhn's as well, because so was I. Just one more point. Prakash said, and I agree with him, that he wouldn't offer the operation unless the patient has tried everything else. From my humble experience and many of my colleagues, especially in the past, I've never had a patient remain compliant with the medications. They are tough medications to take on a daily basis.
Yeah, sorry, Morgan, could I just add one thing? And I would only do 2, 3, and 4 if they've got palmar and axillary hyperhidrosis. If it is palmar, it's only 2, and it depends after that. But for 2, 3, and 4 is only for palmar and axillary hyperhidrosis.
Could I just ask, is Ger McGreal there? Because Ger used to do this with a posterior approach. Or is there anyone there who's worked with Ger and seen that in action? I
don't think so. Sean, could I make one more comment? Again, when I was just listening to Prakash there, he said he's done like 100 cases in 20 years, and that's kind of 4 to 5 a year, which is really are tiny numbers. And that was the main thing that got me to stop doing it about 4 years ago. I found when I started 15 years ago, I was probably doing 5 or 6 a year, and then I was doing like 1 or 2, and I said, this is crazy to be doing a procedure once or twice a year where you're literally going into a cavity that we normally don't do. And like I would have thought that thoracic surgeons who do a lot of lung stuff and they do it thoracoscopically routinely, they're probably a far better group if you are going to do that procedure. And I really strongly feel that vascular surgeons should not be doing this anymore. And I agree with you. So I don't think we'll get an answer, but I just think it's crazy that we're doing this operation still, you know.
Well, anyway, I suppose as everyone can see, there's lots of areas for debate. We could debate it forever.
Yeah.
Sean, I think PH Paul, is that Paul Hart has his hand up there?
Hi.
It's Paul Healy, one of the general surgery SPRs. Just a comment really, and it's interesting on the how Vascular are debating about whether it should be on their own curriculum. Having done the Part A of the FRCS general surgery recently, it was actually a question on what part of the sympathetic chain would you need to damage in order to cause a Horner syndrome. So it's just a comment really, and just interesting on how Vascular are trying to get away from it potentially, and it's still on the general surgery curriculum.
Curriculums die slowly, I think, Paul. Anyway, I think there's some vascular cases. I can't remember, is it upper limb or aortic cases that Emily or Bridget have. So maybe
Can I
we
just make
should
one more
come
comment,
back.
Sean? Sorry, I don't mean to take over. One more comment. You mentioned about Botox injection into the ham or the soles of the feet. I have done it once into the palm. It was many years ago, and it was a 15-year-old girl, and it was very, very painful, even though I did do a block, median nerve block. But secondly, the tissue on the palm of the hand and sole of the feet is probably too thick. I'm just surprised you said there is evidence that it does work. But from, again, speaking in the abstract, the skin is probably too thick for Botox to really have any long-lasting effect. Just a small comment.
Yeah, and I don't do it for the same reason, Morgan. I've tried it and given up. Okay, so I don't know, that Emily or Bridget is going to present a couple of cases, will I?
I have a few cases, but it could be fun trying to screen share now. I did try and do it with Jackie and it worked.
Okay, good.
Sorry, this one. Can people see?
Yeah, case 3 is coming through there, Bridget.
Okay, so this is just maybe a short case. Who are the exam people around there? Mary Conley, can you hear me?
Yeah, I can. I'm speaking.
Okay, so this is just a very quick case, and I hope it works. So this was a gentleman that we just saw in the last few weeks. So he's a 71-year-old male who presented with rest pain. His daughter was very concerned about him, that she thought he wasn't sleeping at night. And he was referred in by his GP. He had a previous history of a CVA. He had a history of AFib and was on warfarin. Had a previous RTA about 20 years ago and had cognitive impairment. So it was difficult enough to get a history of him. And he went to the vascular lab and his pressures were low in the affected foot. It was about 20. So he had an angio, and this is the angio. So I can play through it, what you see. Okay, so I'll play through it again. Do you have a look at it there? Can you see the screen?
Yeah, sorry, just a bit slow coming through, but it is.
Yeah, I'll do it again.
And what symptoms did he have? Sorry, Miss Egan, I missed that.
Rest pain.
Rest pain, okay.
So I'll stop it halfway through. So it was fine above knee. He had a palpofemoral and popliteal pulse.
Mm-hmm.
So just keep an eye on this as it's playing through.
So
okay. He had a fracture. He had a previous fracture of a tib and fib, and you can see. This is the distal image. You could see callus formation. So that's his distal runoff. So just a perineal. And I'll go back to this again and just. He had callus formation here. You can see it on the thing. So what do you think it took us a while to work this one out on the day. So what do you think might be going on here? Talk to me.
So his below knee popliteal looks to be okay. The origin of his AT kind of peters out. His TPT is all right there. And again, he has occlusion of his proximal PT and perineal with reconstitution of his perineal distally. That callus area, I'm not really sure. Is there some venous filling around it or something as well?
Yeah, there is. So it's filling. This was here. You can't see it on the angio. So there was callus formation here, and you could see it on both sides, probably relating to his RTA. And it looked like this is venous filling going back up. And he just filled a perineal downstream. He'd no tissue loss, and it was difficult enough to know the extent of his true symptoms because of his cognitive impairment. So any thoughts? And just as a short case, if you got something like this, what you might do?
So it looks like he's got like an arteriovenous kind of fistula in that region. It seems the vein kind of fills quite quickly. It's not a delayed filling up. And his pressures were 20. So
yes. So where do you think you might go to from here as a possibility?
So I would have thought it was more likely that it was his arterial insufficiency that's causing his problem, and that the arteriovenous fistula, is something secondary. It doesn't look like that it's stealing a huge amount of blood. So I would have thought it was more the arterial insufficiency, and look at revascularization options then. Like to see kind of the foot view. You can see there's just a perineal filling.
Yeah, he's a good perineal, and the vein did fill quite quickly, and it looked like there was a good going back up onto his foot. So do you think, just with his cognitive impairment and that, do you think you might explore any options before you would go diving into revascular? Do you think he's an angioplasty solution? We couldn't get a wire down.
Probably not. It looks like it's long enough. I probably would try, given that he's elderly and cognitive impairment. But I suppose if it's rest pain, it may be worthwhile even just kind of pain control for him if he's 71 with advanced cognitive impairment.
Yeah, okay, and I don't want to dwell too long on it. That is what we did. We did ask the IR people if they thought that embolizing this might just basically reduce the venous outflow, because it did look, I felt on the thing that this was filling very quickly, and that there may be a steel component, and that it was aggravating, what he had left going into his foot. In fact, that this was filling up before his perineal. But they were concerned when initially they thought they could do something, but when they went to it, they were afraid that they would just wipe out his perineal, so they left it. So they said they wouldn't do anything with it because they thought the risk of just, of wiping out and all the feeder vessels going into his perineal. So we did what you said. So we just managed him at the moment for analgesia, with a view, I guess, that if he doesn't settle, he does have a distal vessel. But I hadn't seen something like this before.
Currently, a lot of people doing deep venous arterialization, and if you close this every fistula, he could end losing his leg. So this is God's way of saving his leg. So I think that you have done the right way by leaving him alone. Otherwise, he could open the perineal and allow this fistula to save his leg if he has no runoff. But a lot of people currently now are creating intentionally an AV fistula to the deep venous system, mainly the plantar arch and the long saphenous to the tibial peroneal trunk, in order to do deep arterialization of the venous system. So I think you've done the best option for him for a guy with cognitive impairment.
Yeah, no, I have seen that described, like that's been described for years. I think the Russians used to do a lot of it, but this was the first time I'd seen something like this, and I thought it was unusual, and I thought it was, was a really good, probably short case, just to get people thinking. Okay, very quickly we'll move on. I think I have to screen share again, and this one. Okay, Mike Burke. Mike, are you there?
I am, Ms. Egan, yeah.
Yeah, you're going to curse me now, and I apologise, but these slides are nowhere near as good as Sean's. So this was just a case. Can you see the slides, Mike?
I can indeed, yeah.
So I was asked, he was a 43-year-old man who was admitted with sepsis, and diagnosis, initial swab was negative with COVID-19. He was otherwise fit and healthy, background history of C2H5, but nothing else. And were contacted by the AMU consultant because they were concerned with regard to his legs, and they felt he had markedly swollen legs. They felt very heavy, and his feet had a sort of a dusky appearance. So I'm just going to try and play through his CT. I'll do this twice if it works. Okay, do you want me to go through that again?
If you could, please.
It's hard to see it. They did a CT tap on him because they didn't know where his source of sepsis was. And they called us after that. So remember, bilateral leg swelling. Do you see anything unusual there? It's not the best because it's a CT tap rather than a dedicated.
I have to admit, I followed the arteries the first time. Is his IVC and his common femoral veins, are they quite distended?
Yeah, look at it here. There's his. So look at the way it's all the stranding around it, and how distended his iliac veins are down to his common femoral. So the CT tap came back and they reported it as an extensive bilateral iliofemoral DVT extending up into his cava. So, you know, like a saddle. So what would you do with him?
So he needs to be anticoagulated in the first instance. I imagine heparin. The concern would be if this is going to track more proximally, but I'm not certain whether you could go about putting in a filter from above down. To be honest, I haven't seen that, but the concern would be if this spreads, he could get multiple PEs, if in fact he doesn't have them already. Had he a CT-PA?
No, not at this stage. So now he's COVID. So yes, so that was the first thing. I suggested putting him on IV heparin, and then I went off and read some literature on COVID. I didn't know if it was any different, and I did learn some things with this. And then I spoke to hematology. So they did suggest, hematology suggested IV heparin, but there is issues, and this is important because it's unlikely COVID is going to be around for a while. And, you know, if you came across a case like this, again, there are issues around heparin resistance in patients that are COVID positive. And there are also issues around people, you know, exposure of staff members to taking bloods with regard to, you know, checking APTs, etc. So a lot of the journals talk about giving them subcutaneous heparin, but because he's a iliofemoral DVT was so extensive, our hematologist suggested IV heparin, but you need to be aware of the heparin resistance or a problem with it that is specific to COVID patients. So he had, because they were concerned about his feet, and as you say, initially I was looking at the CT as well, we couldn't really get him to the vascular lab because he was COVID, and we couldn't feel any pulses. So he had a CT angiogram, which was normal. So it was all venous. And I asked them to get his CTPA, and that showed he had mild heart strain with bilateral pulmonary emboli. So what would you do from here? So he's on IV heparin. Anything else you might think about, not necessarily do, but would enter your thought process this time?
I hadn't been aware that it was possible to have heparin resistance, particularly in the COVID population. Is there a way to test for that? Are we certain that he's being adequately covered?
Yeah, no, it's usually they can get a hits, but I have a paper I can get Jackie to send round. There are issues that people have become aware of around heparin resistance. I guess it's a learning curve like a lot of the things, and I'll just go into some more of it here now. But with regard to his mild right heart strain and the pulmonary emboli.
Well, I don't know whether it's indicated to put in a filter, consider a filter in that setting, given that there's an extent to which the horse is bolted. I'm unaware of anything else from there.
Yeah, and I thought about a filter as well, because initially we didn't know, but again, I think there'd be some resistance to probably putting it in and COVID and exposure to patients. So he went on to a apixaban from his heparin, and we put him into compression and everything settled down. So, and he was discharged home. So the issues around the role of thrombolysis are a filter. So I just went then to do a literature search on the specific issues around COVID. So there are communication and guidance on the treatment of venous thromboembolism in hospitalized patients with COVID-19. And there are things that just to be aware of, I guess, that elevated D dimers may not actually be a reliable predictor of a DVT in this population, but where it's very high and above 4, it can be a poor prognostic indicator. They think up to 27% of patients in ICU can have a DVT or can have some sort of venous thromboembolism, and the mortality rates in those patients is very high, and it can be up to 42%. These were things I guess I didn't know. And the incidence of arterial thromboembolism is probably in the order of about 3.7%. So the guidance is low molecular weight heparin in patients that have a high incidence or with their high risk patients. You may consider, increasing their dose of low molecular weight heparin. But the other thing they advise is to beware around that if people are on antivirals or they're immunocompromised and they're on treatment for that actually can interfere with the NOACs and the efficacy of the NOACs, even though a lot of these patients are routinely. So just some very specific areas related to COVID patients. I'll get Jackie to circulate that paper. And then I went to see if there were any, I suppose, cases reported in the literature about putting filters into these patients, and I couldn't. But there was one case report about thrombolysis, because the physicians were saying to me, well, if he had right-sided heart strain, should we thrombolyse him? Now, he settled and we got away without doing it. So I could only find one paper in the literature with two cases, and there was the author of the paper had a conflict. He said, I think he was involved in the device that they used to do the thrombolysis, but both patients did well. And just, I guess, for, again, people doing exams and that, to be aware of the CAVA trial, which is looking at iliofemoral DVT in general and looking at whether or not there's benefit in preventing post-phlebitic limb down the line, and it would suggest that at 1 year there is no real difference in patients treated with thrombolysis or not. But there are some issues around whether or not those patients that had an iliofemoral DVT versus just a femoral DVT, that if they split them, that they may have been a slightly improved outcome in the patients with an iliofemoral DVT. So the CAVA trial and the ATTRACT trial is the other one that you probably just need to be aware of. And I might just ask Jackie to circulate those after the meeting. So just slightly different management and just a few nuances in patients with COVID. Okay. And then just very quickly, one last one. So who else is there? That is Mary, Natalie. Are you there still?
Yeah.
Do you mind just going through this? Sure. Can you see the slides?
I can, yeah.
Okay, so 71-year-old male referred to hematology for investigation of anemia. He had a history of just hypertension, non-insulin dependent diabetes, and he was on aspirin, a statin, and antihypertensives. And the hematologists really weren't sure what was going on, but they thought they felt a mass in his abdomen, so they referred him for a CT. So this is what the CT showed. So no prizes for guessing that.
So he's a large AAA.
Okay, so what do you think, just eyeballing the scan?
Well, the neck doesn't look very suitable for EVAR. I prefer an angio, like a CT angio, but there's quite an angulated anterior neck. I think it's involving, are they the renal arteries coming off there on the first?
Yeah, I hadn't quite worked out how to do the video at this stage, but I tried to, yeah. So initially it looked like he was probably just about suitable based on his CT when you see all the slices. So we were ready to do him, and lo and behold, the rest of his CTs reported, and this comes back.
So what? Empyema, is it, or is it a tumor, a lung tumor?
It's a tumor.
Yeah.
So on the same scan, so what would you do now?
So he's only 72. I obviously don't have a measurement of that AAA, but it looks to be at least maybe 7 centimeters.
10. Sorry, 10. I should have. Yeah.
Grand. If he is asymptomatic, like he's not tender in the abdomen or any back pain, I'd keep him as an inpatient, obviously, on a surgical ward with everything ready. I'd probably get the respiratory physicians to see the patient for kind of lung function tests and also for high-res CT thorax. that looks peripheral, so it could be biopsied.
Okay. And it was.
However, I would say that they would want you before, if he was suitable, it's probably, you know, an adeno, squamous cell there. So if he doesn't have any nodes positive on his CT thorax, he would be a candidate for resection if his lung function was okay. So I'd say if he was suitable for EVAR, he should proceed for EVAR first, and then resection later.
Yeah, so he did. So they did. They did a biopsy, and then they sent him for a PET scan to James's, and he just had one. They queried a node, so he had a nebus, but that was negative. So they reassured us, the respiratory, their MDT, that he was suitable. So we stented him, and that is his. That's just his completion angio.
Yeah.
So he that was in August. There was no endoleak on CT. I saw him back in the clinic, and he went for pneumonectomy in October. And this was his, so he was a stage 3A. So he had actually no nodes. He had a complete resection. So it was a T4 N0. So just, are you aware, and I just went back into it, about the guidelines with regard to patients presenting with a combined malignancy and aneurysms? I put it up there by mistake. Are you aware of any of the guidelines?
No, I wasn't.
So just again, just I suppose to be aware of them, the ESVS guidelines have a page dedicated, and they say that the management of, you know, where a patient presents with a AAA and an abdominal neoplasm, looking at different studies, they came to the conclusion you should treat what is most threatening or symptomatic first. So be it that the AAA or the cancer, but that in some cases, depending on the malignancy, where it really depends on the stage, the type and the grading of the malignancy. Obviously the outcomes for people with colorectal cancer are much better, lung cancer less so, and pancreatic cancer, and that should be taken into account before considering treatment, because the survival correlates with the stage of these cancers. So again, if you got, you know, if you had a case like this, or we're discussing a case like this, just to be aware that there are some guidelines out there, and that you could reference them in any discussions to back up whatever decision you make. Okay, that's it. Any questions?
Bridget? Just a comment, Bridget. I find that when other specialists, for whatever reason, do a scan and find an aneurysm, that they stop then whatever they were actually trying to treat in the first place, and it's very hard to get them to engage with staging it and making a decision. And frequently, I've had at least 2 cases where we go ahead and we fix the aneurysm, and then decide that this patient is unresectable, pancreatic or gastric carcinoma, and decide to treat them palliatively.
Yeah.
Having asked them beforehand, well, are you going to do an operation if we fix this? They just won't focus on it until it's until the aneurysm is sorted.
Yeah, no, and like I have to say, when I saw that guy's lung tumor, I really felt, and I spoke to you about it at the time, you know, that, you know, what were we at? But anyway, I just put him up really just for that decision-making process around, you know, to do what, when, and that there is at least reference in the guidelines, and that you could, just to be aware of those if you were discussing a case. Okay, thank you. Yes, Prakash.
Nice case, and I think this is something that we all struggle with at times, you know, when concomitant pathology is found, which do we treat first? How do we treat it? Should we treat it at all?
Yeah,
and, you know, it's sometimes not an easy call, because, you know, when we as vascular surgeons see an aneurysm, sometimes all you're focused on is treating that, and it may not be the right thing to do for the patient. But looking at that run, that's not a device you normally use. So how did you choose to use that device?
It's a Cook.
Is it a Cook device?
Yeah. Actually, okay. You need to get your glasses tested. Come here, just as you're on that, that's a really, I don't know if you saw this this month's European Journal, and there's an editorial piece on the treatment of aneurysms and the risk, and saying that we now, in light of COVID and the fact that everything was put back, and actually all these patients that are out there, not many of them have ruptured, that and if you look at the risk of rupture in a 5.5 centimeter aneurysm is something like 0.4% per year. And it was just what the journal that came yesterday, that we really need to go and look at all of this again. It's well worth reading. Certainly provoke a discussion sometime at some meeting. Thank you.
Bridget, can I just make a comment? Hello.
Hi, Bridget. I have at the moment I think 5 or 6 aneurysms that are between 5.6 and 7 centimeters, and with the whole COVID thing, I'm in no rush to treat any of them until such time as, especially the older patients, have been vaccinated, and hopefully maybe by April, May, I might be in a position, but certainly I'm in no rush to treat them at the moment.
Yeah, I think that's because they don't just do well, do they, our patients, when they get COVID?
Yeah, well, I think if you get them vaccinated, and they should all the over 70s hopefully would be vaccinated probably by the end of April.
Yeah.
And then we can probably start to maybe at least treat them more safely, you know. So.
Yeah.
But I agree. I think the risk of rupture of a 5.5 or even a 6 centimeter aneurysm is fairly low, and we can wait.
Morgan, sorry, were you trying to say something there?
Sorry, okay. Can you hear me?
Yeah, I can hear you, yeah.
No, I was just going to pass a comment on the concomitant malignancy with the AAA, just for those doing the exam, if they get anybody from the Manchester area in the exam in part 2, a lot of work was done on an abdominal malignancy and a AAA being diagnosed at the same time. And, you know, I don't know how robust the data is. I haven't looked at it in a long, long time, but there is an incidence of increased risk of rupture when a patient is undergoing treatment for another abdominal pathology other than the aneurysm, just to make them aware of that.
But that's old data, isn't it? I mean, that was when we were going through training. They told us that if you had a laparotomy and you're in an aneurysm, that it was much more likely to rupture.
No, I absolutely agree, and it is old data. It's kind of still hanging around some of the older Manchester crowds because that's where it was done originally. But I agree with you. I think with the advent of EVAR, it's a bit different now.
Yeah. No, these are always diagnostic dilemmas. Anyway, thank you. I hope those helped people.
So we've two, it's after 7. We've 2 more cases. We've a long one and a shorter one, and we can just do one or both or neither if people don't want to stay on after 7. So.
I go ahead.
Yeah, but maybe we have to move to the short one anyway.
I'll just share. The share, is it?
I hope so.
So can people see that?
Yep.
Great.
Okay, so I just put this one on because I suppose it was in keeping with it being an upper limb topic. It's not a very original case, but just to discuss it. So it was a 54-year-old man, right-hand dominant. He'd come into Tallaght A&E after a relatively minor trauma. He'd fallen about 5 feet off a stepladder. He was doing some DIY at home. He's trying to clear out a gutter or something, but fell off and landed on his left elbow. It was an isolated injury, so he had nothing else going on except for the arm injury. And he kind of noticed immediately he had a deformity of at the elbow, and there was an open wound. So he's brought into A&E. The elbow was reduced because it was dislocated, and then a CT angio was done because it was noted in A&E that he had no radial pulse. Now he's brought in. The accident happened at noon. He brought into A&E and wasn't CT'd quite later on that evening. So then we got a consult. We're asked for consult at about
Hello.
Hello.
No.
Sean, your microphone's on there.
No. Are you? I'm just. Okay. No, I'm finished. Are you coming in? Yeah, absolutely. Yeah. Thank you.
Go ahead there. He's off there now.
Oh, sure. Yeah. So we saw him that evening. So about 9 hours after the injury. So his left hand, he had some paresthesia. So all the fingers were affected. It wasn't a particular nerve group. He had some weakness of finger flexion, but his hand was actually quite warm. He didn't have any pulses or any signals, and he had very good signals on the opposite side. And then on looking at the wound itself was quite small. He had a small, essentially a puncture wound on the elbow. If I'll show you the next picture. So a fairly small wound, and actually he's got a kind of an abrasion either side. So the wound itself is actually very, very small. It's just really 2 or 3 centimeters across. So very minor. So he had a plain film in A&E after the reduction. So after the reduction, he had no fracture, and there was a reasonable result. So the CT angio, I'll just show you, this wasn't particularly informative, but I'll show you the pictures anyway. So essentially, was normal down to just above the elbow, and then the contrast disappeared suddenly, and he had no more contrast below that. He did have filling of his ulnar from collaterals, but nothing in his radial. So it didn't really add a huge amount to the clinical picture, and it was hard to say from that if he had a complete transection or just a subintimal injury or whatever else might be what else might be going on. So I might ask then someone who's what they do next. So is Tom online?
Yeah.
Oh hi. So yeah, you've seen the CT. It's about 9 hours after the injury. He has some neurology. So what would you do? Would you do something that evening? Would you wait till the next day?
Yeah, I'd be inclined to do something that evening. I'd certainly think about exploring the wound. You didn't want to have a plastic surgeon on hand as well if you're concerned he's a median nerve injury. I suppose depending what you find, then I suppose you may need an interposition graft or with vein or something like that if his brachial artery is occluded.
Yeah, and in terms of the wound, how do you approach it? I mean, I suppose you saw he's got a small wound already from the trauma. So what would your approach be?
I suppose if you had any way of making that into a lazy S or something like that, is it kind of just across his antecubital fossa, is it?
Yeah, it's a bit it's a bit medial, it's quite small, but it's certainly in around the right region. So
yeah, so I think if you tried to kind of extend it into a lazy S so that you could you get the brachial proximally and the bifurcation then distally. So hopefully you could kind of explore the injured bit of the artery.
Okay, yeah, great. That's what we did. So yeah, we took him to theatre that evening, and we were concerned about the neurology, and I didn't think it could be explained just by an injury, a median nerve injury, because it wasn't specific to that nerve. So we took him to theatre. It was probably a bit worse than what we thought, and that was kind of the main learning point for me from the case, because the injury looked fairly innocuous. But he actually had a very large cavity under the skin. His muscle had been torn. His joint was exposed and was kind of palpable through the wound. His median nerve was actually intact, but I'm sure had been kind of injured to a degree. His brachial artery was completely severed. It was in 2 pieces, and the ends were very damaged, very thrombosed. The brachial veins were also completely transected. Actually, his basilic and cephalic veins looked intact, so his superficial veins had missed kind of the worst of it. So we explored, extended the wound. We were able to locate his proximal artery very easily, and there was good inflow once we kind of explored it. It was actually quite hard to locate the distal end of it, even though, I mean, the wound is quite small. We located it kind of quite early, but it's quite small caliber. And although I suppose you expect it to be small caliber with vasospasm, which is quite different caliber to the proximal end. But anyway, we couldn't find anything else. And then we had to resect back on both ends to quite about 1 or 2 centimeters at least, because of the injury to the ends of the vessel. So as Tom suggested, then we used an interposition graft. We actually were able to get some median cubital vein, which is quite good quality, and it was in the wound. So we used that as our interposition graft instead of going for saphenous. There wasn't great back bleeding. We passed it focally distally and didn't get a thrombocyte. So then when we finished the graft, it looked like there was a small tear on the distal brachial artery, and I think in retrospect it was probably had been caused by the fogarty, because the vessel had spasm was quite small in caliber. So we repaired that. We attempted to repair it just with a 7/0 suture, and then we couldn't kind of fully fix the tear. I was reluctant to do a more formal repair because the artery was small caliber anyway. So I decided to patch it. So I ended up taking some GSV in the end, although we hadn't planned to initially, and use that to patch it. And that worked well initially. There was initially a good signal in the graft, and then it became a bit obstructive. So we gave him more heparin, had to open the patch, do an embolectomy and get more thrombus, and then eventually got it to work. And then we washed it out and put on a back slab. So I expected it to be a fairly straightforward operation, but it actually was a bit more complicated than what I'd anticipated, which I suppose isn't unusual for trauma. So then post-op he did fine. On day 1 his hand was warm. He had a palpable radial pulse. We decided to keep him on heparin for the first day or so. I was kind of concerned about the fact that he seemed to have occluded the graft interrupt, so we kept him on heparin for the first few days. Obviously continued the antibiotics. Despite how extensive the wound was, he didn't actually end up requiring any further input from orthopedics apart from a wound washout, which they did about 4 or 5 days later. He subsequently had an MRI, and his median nerve had been injured, but didn't require any formal expiration. Wasn't transected, and then he was put in a splint. We switched him to aspirin after a few days and progressed, and he actually fully healed by about a month post-op with a negative pressure dressing. So he did quite well ultimately. And just this isn't a trauma talk, but I just wanted to briefly go over just kind of upper limb, I suppose, vascular injuries. When you look at most serious that are reported, we look at what's injured. I suppose it's reported that the brachial artery is injured about 40 to 55% of upper limb vascular trauma. But actually, when you look at the pattern of injuries, it's more common probably to injure the arteries distal to the brachial. So the radial and ulnar are most commonly injured, then brachial, and then the more proximal arteries are less frequently injured. And again, just looking at what the experience of the centres is, again, most of these injuries are going to happen in young males. They're often penetrating injuries. The previous slide showed injuries from combat, but even in just kind of more civilian settings, that pattern of injury tends to be the same, with the majority being in the radial and ulnar arteries, less commonly brachial, and then less commonly, again, more proximal. Most repairs are as we did in our case with using vein graft. Although primary repair can be done in some cases, I think that's going to be more common when the artery hasn't been completely transected. So if you have it's just like a subintimal flap or an injury where the artery is partially intact, I think then a primary repair may be feasible. But I think in the setting of trauma, when the artery has been transected, a primary repair is going to be very difficult, given the fact that the ends are probably going to be injured too. So it make it quite difficult to do it. This just shows a series from Ireland, it's a few years old, from Limerick. And I think the point of this was just to show that vascular trauma requiring repair is relatively rare. So this was a 13-year study, and there were 35 cases in it, and about 11 of those were brachial artery injuries. So they're not things that happen, I suppose, very frequently. And just again, I looked at the syllabus too, and I think it's recognised that because of the relative rarity and unpredictability of vascular trauma, it can be hard to obtain competencies just on the job. And there is kind of a role for, I suppose, attending courses and so on to try and supplement trauma teaching, because it can be hard to get enough exposure to it on a day-to-day basis. So I just put that case up as an example of how I think the injury was certainly more severe than what it looked initially. But I think we had to go ahead and do it that same day because he had a neurological deficit. I think the upper limb is very forgiving. I've certainly seen cases where you can have a pink warm hand on the arteries in 2 pieces. So I'd say don't be fooled by maybe the clinical appearance of the upper limb in particular, because it can be a bit more deceptive than the lower limb. And I think if you've any doubt at all, you should go ahead and deal with it that day. And the CT in this case, as is often the case, wasn't particularly informative and didn't really, I suppose, convey the complexity, I suppose, of the injury that actually that was there. And then, as in this case, kind of venous injuries, if it's feasible to repair them, you can consider it. But I think in the setting of trauma, it's safer just to ligate veins that are transected and just focus on the artery. So any questions on that? Or?
Ms. Boyle, Sean Maguire here. Can I ask about your choice of interposition graft? You said you used the median cubital vein on the same side. If he's had extensive venous damage already, was this already transected, or is it a fresh vein? Would you have considered taking a vein from the other side to prevent swelling afterwards?
That's a good question, and that's actually why we kind of used what we did, because although he'd managed to sever his deep veins, his cephalic and his basilic and his median cubital vein were all actually intact, and we're able to resect a short segment of the median cubital without actually compromising his basilic or his cephalic. And then further on, when we end up needing a further vein patch, that was why I ended up going for saphenous, because I was reluctant to interrupt his cephalic or his basilic, given the fact that he'd already lost his deep veins. Now, I think realistically, even if you did go ahead and take his cephalic or basilic too, I don't think arm swelling would have been a huge issue, but that was why I did that. For that very reason. And I think actually, like great saphenous vein, it's probably a better quality vein in general to take as a graft, but we initially took median cubital because it was there and it avoided making another incision. As it turned out, his saphenous vein was kind of quite large caliber but quite thickened. And although it was certainly usable, had we used that for a graft initially, there would have been quite a big size discrepancy between the great saphenous and the brachial artery. And while it probably would have been possible to do it, I think actually we had a better solution with the median cubital vein for the interposition graft. So yeah, and I suppose I think every case is probably going to be different. I think if you have usable vein in your field that looks like it's easy to use, it's probably you can go ahead and use that. And if that isn't available, I think saphenous should be your next choice.
Thanks.
Can I just ask Emily or anyone, what would you do when you go in? The neurological status seemed to be okay with the usual caveats, and you go in and you find the median nerve is also divided. It's not an uncommon scenario. And plastics have said, we're not interested until the artery is dealt with because it's an ischemic arm. Anyway, what would you do, or what would people do? Do I have to pick volunteers? Who hasn't been picked so far?
I think if it's been transected, Prof, would you not, like, even if you just go ahead with the arterial repair and ask plastics to come in then at the end of the case? No.
Okay, but they're not everywhere though. Plastics aren't necessarily on site. So what would you do?
I probably would be slow to fix it by myself. It's his dominant hand. He's 55. I think I'd make sure that a plastic surgeon is on the way to come and that they were forewarned, as Tom said, going to theatre. Like a 55-year-old and you're repairing his median and his dominant hand, I just wouldn't be confident that I would give him the best functional outcome from that.
Tom is going to fix it, yeah?
I fixed it with you when I was there in Tallaght.
Okay, that's fine then, yeah.
That must be the right answer then, Sean.
That's right. No, I mean, I don't know the right answer. I mean, in fact, the plastics people wouldn't fix it for a couple of days anyway. So one option is to fix the artery, leave the vein, and they can go in a day or two and fix it. But the temptation certainly is to fix it at the time. And that's what I've done when it has arisen. But I take Mary's point. If you had plastics on site, I'd certainly let them at it.
I think my plan in this case, I mean, I was going in, I suppose the artery was so badly damaged. I think he was lucky that he hadn't transected his median, and you could actually see it was looking. We could see it looking at us. So the whole thing had been kind of opened up, and it was there, very visible in the wound. But I think had it been in two pieces, we'd probably have done the arterial repair, put a dressing on, and kind of sent it to plastics the next day. For the same reason that they're not kind of on site here, and they wouldn't have been around it in the middle of the night. But I probably wouldn't fix a median nerve myself either, I have to say.
Sean, Xenia here. I know one of the first operations we learned how to do in the College of Surgeons was to fix a nerve. Now, I've never fixed a nerve myself, but I think I'd do the same. I think, fix the artery and wait for plastics to fix it. As you say, they can do a delayed repair.
Yeah, I mean, either a few days or even later, yeah. Hi, Morgan, yeah.
Yeah, I would say it depends on the energy involved. Obviously, if the best thing is to mark it. If you find the nerve in two pieces, mark it so that the plastics can actually find it when they decide to go back in. If it was, say, a gunshot wound or blunt trauma that has torn it apart, then you're going to have axonal degeneration over the next 28 days anyway, and most plastic surgeons should do a delayed repair. If it's a knife wound or glass, then certainly you can approximate it and mark it and then give it the plastics, but there's no rush to fix it.
Sounds good.
Actually, if Morgan's on the line, I just wanted to ask, have you ever had a situation where you've had a transected artery and been able to do a primary repair without having to use an interposition graft?
No, I'll be honest.
Yeah.
It's described in the books, especially in young people. When if you completely transect the vessel, it as you saw, it completely contracts away.
Yeah.
So even if you free it up, getting attention-free end-to-end anastomosis is almost impossible. So I think he did the right thing. And going back to Sean McGuire, was it Sean McGuire asked the question? I think he did the right thing. I would use upper limb vein from the same side. We make renal access out of these upper limb veins. They're very, very robust. They do last. In fact, they last probably as long as a saphenous vein. I would take it from the same side. There is an adage that if you have lower limb trauma, you should take the bypass from the opposite leg, so you preserve whatever outflow, venous outflow they have. To be honest, if the profunda veins, even the lower limb, are still intact, that's probably more of a theoretical risk than anything else. But I think this was managed perfectly. The only caveat I would say is, what if you had a fracture? What if you had a really complex fracture and orthopedics need to get involved? Then it does add some complexity to it, and really it should be externally fixed. And there's nothing more soul destroying than you fixing it with your interposition graft or bypass, whichever you chose, and then orthopedics get involved, and then they call you back 4 hours later and say your graft is thrombosed, and that's a real irritation.
Yeah, they can usually put on a quick external fixator first, Morgan. That's probably about 2 hours in my experience.
Absolutely.
Sometimes longer.
It's like a 20-minute CT scan. 2 hours later, the patient's still there. You know.
So were you suggesting to use a shunt, Morgan, were you, while they put the X-Fix on, then come back?
Yeah, look, I think that's reasonable. You can put a shunt in and go off and tell them to call you back when they've got their X-Fix on. I guess shunts aren't great below the elbow. That's the only thing. They're not great below the elbow. They do thrombose off. But again, as Emily said, the upper limb is very, very forgiving. So you could certainly do it. Do your embolectomy, put loads and loads of heptasaline down, put your shunt in and see, and then go off and come back. And hopefully you get away without doing a forearm fasciotomy. Although I have to say I have a very low threshold for doing forearm fasciotomies, even though the upper limb is more resistant, simply because if you get it wrong, and even if you leave them with an ischemic neuritis, even some upper limb pain, it can be very, very disabling. That's just my opinion.
Morgan,
yeah, sorry.
No, can I just? I was just going to ask you that. No, Morgan, when would you do fasciotomy? Would you extend the fasciotomy into the hand?
Yeah, I think fasciotomy. Yeah, it's all or nothing. Yeah. So obviously, you're going across two joints. You're going across the antecubital fossa. You make a wavy volar or flexor surface incision. And I go into the palmar fascia for about 2 or 3 centimeters, and I cut it with a scissors. It's relatively free of any vessels there, and I divide the flexor retinaculum, and I make it look like it looks really ugly. It looks really, sensationalist. But I think if you're going to do it in the upper limb, you have to do it properly. Otherwise, if you get it wrong, they can be left with a chronic problem with that upper limb.
Morgan, I've heard you talk about using prosthetic before in the lower limb if you're stuck for vein, even in trauma. Would you have the same opinion on upper limb or not?
Yeah, it doesn't bother me. I think once you have viable muscle cover, you'll get away with it. Most of the studies looking at, if you go back to the literature, most of the studies comparing vein to synthetic graft are for chronic ischemia, ulceration, critical ischemia, where you've got a different set of bugs involved. This is a brand new, trauma. Generally, you've got healthy tissue. The rest of the blood supply is fine. The muscle is fine, and you should get good cover. So as long as you've got good cover, I have no problem, including gunshot wounds. I would have no problem using synthetic graft. And in fact, if you do go to the literature, the actual difference between infection rates in vein and infection rates in synthetic is very, very small. The main difference is how they behave. So if you get an infected venous graft, it'll dissolve and it'll perforate and it'll blow. If you get an infected synthetic graft, it'll just stay infected and pus out until you take it out. So it's how they behave rather than the prevalence of infection. But there's no randomized level 1 controlled trials. If anyone's going to ask that question, they don't exist.
Do I think, Morgan, I mean, I've used plastic, down sort of in the arm and up in the subclavian axillary area, but I suppose when you're down with radial and ulnar arteries, it's probably too small in most cases to be a realistic choice, isn't it?
Yeah, no, sorry, I agree. What I should have said was, I'm not concerned about the difference in infection rate between synthetic and biologic in the trauma setting. With regards to longevity, absolutely, vein does last longer. And I agree with that, especially when you go below the elbow or below the knee. There's no doubt about that. But you have other options. I mean, you got to deal with what you got. 2 in the morning, you got to deal. You got to get out of Dodge and come back and fight another day. So if your synthetic gets you out of that trouble, and 6 weeks later your synthetic is causing trouble, it's going down, or it's thrombosed off, you got choices then. You don't have to do a perfect operation. The problem doing a perfect operation 2 in the morning in a trauma setting is even your biologic graft will thrombose off because this patient's already relatively coagulopathic. So you have to kind of weigh the two up, doing the perfect operation now and it failing and having no options, or doing a decent operation now and coming back with options later.
But I often think that when these have gone down on me later on, you don't need to go back because they're well collateralized. I think the problem in the first instance is they're a bit hypotensive, they're a bit vasoconstricted. There's lots of other things going on for whatever the original injury was, and they need to be fixed then, but they don't actually need it in the medium to long term.
Agreed, 100% agreed. I can't disagree with that. And again, going back to the median nerve thing, when it comes to the mangled extremity, so if you've got a lower limb and you've got multi-system involved, you've got skeletal, you got vascular, and you got neurologic injury, the number one cause, the number one issue that will end up with a lower limb amputation. I can't comment on the upper limb, the data isn't robust, but on the lower limb is a neurological complication. So if you've got a mangled extremity and the nerves are all mangled, even if you do a fantastic bypass and get good muscle cover, you'll still be left with a useless, painful limb. And that's the number one reason why these patients end up going on to amputation.
But again, Morgan, it's quite challenging, isn't it, when you have an hour or two really in relation to revascularization to decide not to do it because there's lots of other injuries, because often the patient has been intubated and it's very hard to make that assessment, and sometimes it's easier to revascularize it even if you know that it may end up being amputated.
Oh, 100%. I would still do exactly what was done. And in fact, the 4 to 6 hour ischemic window that people talk about, that was really designed in dogs in the 1970s and in peripheral vascular disease. It wasn't as a trauma. So the 4 to 6 hour rule that you can wait, say, a lower limb, it was all done for amputation. It wasn't done for good functional outcome. So in fact, in trauma, if you've got a hypertensive patient, lost a lot of blood, bit coagulopathic, has multi-system injuries, and you want to revascularize, really, if you want a good functional outcome, you have to revascularize within an hour. I'm not saying don't if it's beyond an hour. All I'm saying is you don't wait. You don't aim for that 4 to 6 hour window. You got to get on and do it now.
And just one other point about the fasciotomies. I mean, the blunt traumas and the gunshot wounds, have a lot of other tissue injury. Often these sharp, like this was dislocation, but a lot of these are often armed through a glass door or window. And often they aren't so bad and they're not that ischemic, but you need to obviously go in and explore the thing anyway. And it's often easier to fix it than do anything else. But they seem to me anyway to be probably at lower risk of the sort of compartment type syndrome afterwards. Whether you can quantify the risk or not, I don't know. But
yeah, I can't quantify it, to be honest. My rule of thumb is if a patient comes in with a hard sign of vascular injury, say they've punched a window and they've torn their brachial artery, that's the kind of typical scenario. They have a hard sign of vascular injury, I'll go in and explore it and repair it, ideally that night. Even if the cap refill in the hand is normal. There are other people who disagree with that, who say, no, it can wait. But I think this is managed absolutely 100%, So I think if, they had a normal blood supply before they punched the window, they no longer have a normal blood supply, I think you should go on and repair it.
What would you do if they came in having put both their arms through a glass window? As happened to me one New Year's Day, I spent New Year's Day putting some fellas. I suppose you do their dominant hand first if you could find out what that was. Presumably.
Yeah, I suppose, or you could shunt them, and that buys you a bit more time, and then do one. I don't know. That's very unusual. What? Yeah, I mean, so when you punch the window once, you do yourself damage, and then you punch it again.
You could have done a randomized trial, Bridget, seeing as you had
2 arms.
If anyone wants to go and do a fellowship in Australia, it's very, very common for the Australian man on a Saturday night to punch windows. I don't know why, but it is.
Fully anesthetized beforehand, Morgan.
Probably better than punching whoever irritated him.
Okay, Emily, I imagine if you want to do the last case, it's 7:30, whatever you.
We might. It's kind of a complicated enough one, so I think it's worth discussing. We might save it for another day because we have it ready, so we can do it hopefully on a different occasion.
That's great. There is one more train day left that's not filled, so.
Okay.
So you just volunteered. Well done.
Sounds like I have. Yeah.
Listen, thanks to Tallaght. They were great cases and great talks, and thanks to I think we'd over 40 people at one stage online there, which is great. Okay. Thanks, everyone.
Thanks, everyone.
Thanks a million.
Thank you
Bye.
very much. Bye. Bye.